panel of physicians, Dr. Timothy Winter, Dr. Eunice Kahara, Dr. Victoria Williams, Dr. Hal Schwartzstein, and Dr. Austin Bach. We need another chair. They're going to be discussing pediatric neuro-ophthalmology and oculoplastic case studies.
Okay. Hi, I'm Hal Schwartzstein. Welcome. This will be an unusual pediatric neuro-oph and plastics case combined. I have no financial relationships to disclose. Upon completion of this presentation, attendees should be able to identify mimickers of third cranial nerve palsy, create a broader differential of ptosis, recognize the need for genetic testing, and recognize the surgical risks associated with congenital fibrosis of the extraocular muscles. Maybe a little bit of a giveaway. But, for the presentation, the chief complaint was the eyes are turning out. On HPI, the 10-month-old female had a history of bilateral congenital ptosis, status post-repair 3 months ago. She was presenting for her left eye greater than right eye turning out, as per her parents. She was treated by her prior pediatric ophthalmologist for amblyopia of the left eye by 2 hours a day patching of the right eye. Past medical history was normal. Past ocular history, she had but she had the developmental delay. Past ocular history, she had congenital ptosis, status post-repair. Her family history was significant for strabismus of a paternal cousin, and the eye drops were none. On exam, she had visual acuity of central unsteady maintained for the right eye and central unsteady unmaintained for the left. On EOMs, the left eye had -4 adduction. It was difficult to assess elevation depression due to the ptosis and developmental delay. On sensory motor exam, she had a left exotropia at near of 90 to 100 prism diopters. Her head position was 10 to 15 degrees of a chin-up head position. She had, in general exam, hypertelorism, high-pitched cry, and bilateral facial weakness. Cycloplegic refraction showed +2.5, +5 at 90, and in the left eye, +6, +3 at 85. On external exam, she had ptosis of the right eye, right upper eyelid, MRD1 of 1 millimeter, and MRD1 in the left eye of 0 millimeters. And the posterior exam was normal. So the information we had so far is that there's developmental delay, bilateral congenital ptosis, bilateral facial weakness, hypertelorism, refractive amblyopia of the left more than the right eye, and a left exotropia. So what would your next step be? There you go, next slide. Oh, yeah, okay.
So this is interactive. If you want to go ahead and participate, you can pull up your phones and enter your diagnosis.
How long should we give?
I think we're just missing some Jeopardy music.
Okay. Yeah. Oh.
This is interesting.
Yeah. We're good? Yeah? All right. Let's see. Oh, okay. What do I, for this one, do I just hit next, or when we leave it, or?
You just have to click on. Yeah, you just click next. Click this one, and it'll go.
Yeah, a couple other notes that pop up for bilateral congenital ptosis. It was status post-repair. However, it is still significant, left eye more than the right. And the amblyopia, we gave the full cycloplegic refraction and started patching the right eye. And then for the differential, we've got left cranial nerve 3 palsy, bilateral atypical Mobius syndrome without cranial nerve 6 palsy, bilateral cranial nerve 7 palsy, and congenital fibrosis of the extraocular muscles. Okay. For the next step, we have some imaging. The MRI of the brain without contrast showed the facial nerve is well identified bilaterally. Of note, the left facial nerve was somewhat diminutive than the right eye. A left middle cranial fossa arachnoid cyst is identified measuring 1.2 centimeters by 2.2 centimeters, but not as important. For the genetic evaluation, family history is reported unremarkable with no known history of genetic disorders and no history of consanguinity. The geneticist did a summary of kind of what we've seen so far, but she did the whole exome sequencing that showed a de novo pathogenic variant of TUB3 mutation. Variants in TUB3 are associated with congenital fibrosis of the extraocular muscles, with or without ptosis, isolated brain malformations, or with a more extensive phenotype of atypical Mobius syndrome. So what is CFEOM? It's a subset of congenital cranial dysinnervation disorders, which primarily affect motility. It's a group of rare developmental defects of cranial nerves and their nuclei. It results in dysinnervation and secondary abnormal EOM structure. The EOMs become hypoplastic and replaced by fibrous tissue. It manifests as clinically as congenital non-progressive ophthalmoplegia with concomitant restrictive strabismus and ptosis. The differential diagnosis of CFEOM is cranial nerve 3 palsy, Mobius syndrome, Duane syndrome, myasthenia gravis, and myotonic dystrophy 1, as well as other rare syndromes. There are 3 subtypes of CFEOM. There's type 1, which is autosomal dominant, has severe bilateral ptosis and restricted superduction. Type 2 has severe ptosis. It's autosomal recessive. They have XT, sometimes retinal dystrophy. And type 3 is a mutation of TUB3, has autosomal dominant inheritance, has a broad phenotype, and can be unilateral. And there's also Tuchel syndrome with CFEOM with limb abnormalities. To make the diagnosis, you do genetic testing and imaging. And in the photos toward the bottom, is there a way to make like a pointer for this? Yeah. Oh, I think, is it this here? Yeah, okay. Laser pointer. Oh, oh okay. Yeah. All right. So you can see the ptosis here, the exotropia. This shows some iris irregularities. It's not completely round. It's a little bit off. And then you see the ptosis again and the exotropia. Diagnosis of TUB3 mutation is associated For our patient, they had a diagnosis of TUB3 mutation. It was associated with CFEOM3. The surgical intervention was likely to result in a poor outcome. Unhappy with our recommendation not to do surgery for her XT, the parents sought a second opinion. The parents did not disclose the genetic diagnosis to the other doctor. And the outside pediatric ophthalmologist decided to perform a recess and resect of the left eye. During the surgery, while hooking the lateral rectus, the sclera tore, the choroid was visible. They called in a retina specialist, and they confirmed that the retina was not violated. They proceeded to repair the sclera with vicryl sutures, and then the medial rectus was plicated instead of resected to avoid, ripping off the sclera again. 3 years post-op, she has a variable XT from 20 to 45 prism diopters. The treatment of the exposure keratopathy is a challenge, and the outside pediatric ophthalmologist is still contemplating surgery on the right eye in the future. Those are my references. Thank you to the consulting doctors. And if we have time for comments or questions now, or that's for the end.
Yeah, I do. I have a question for Dr. Williams. When I only do slings. I don't do like the little ones. I usually don't have any issues with exposure. I just tell them to lubricate a lot with like ointment or something for. It's usually a week or two, max a month. But Hal was just saying probably because of the CFEOM, this one is getting exposure. I don't know if you've operated on these before. What would you do? Would you do anything differently? Because I just say it'll come down eventually and they'll be able to close it for the regular ones.
I actually don't operate too much on kids, so I don't do too many of those. But my recommendations at that point would be like moisture chamber goggles at nighttime, ointment, because that's not something that's going to go away just because of the underlying disease.
Other things I've used or seen used are punctal plugs, punctal cautery. Sometimes I've seen a scleral contact lens used, and that provides protection for the corneal surface as well.
Yeah.
Yeah.
Medical things on that, I'm just not sure how it all works. Say you were in a rural area and there wasn't a retina specialist, and then you were scared to damage the retina, or maybe when the scleras will work,
Mhm.
what would you do at that point if they didn't have a consult?
So that's part of the point why I want to present it, is that my recommendation was not to do surgery, because I don't think I would have had a retina specialist to do that. And I'm glad that doctor did. He was down the hall. I was like, fantastic. But when I operate, the retina specialist is not down the hall. So I think it was very risky to do the surgery. I say good for him, not for me. But I think it's important to think about when not to operate. Yeah.
Okay, I'm Victoria Williams. I do neuro-ophthalmology and oculoplastics in Detroit, Michigan. I'm going to present a case that I saw of a 16-year-old girl who presented with sudden vision loss with an atypical presentation in the right eye. So this is a 16-year-old girl who presented to me same day from retina. She had a 10-day history of sudden vision loss involving the right eye. She says that in early January of this year, she had a sore throat for a couple of days that went away. And then around the 10th, she noticed sudden vision loss with a right-sided headache, a black spot in her vision centrally, and it progressed to kind of just being the superior portion of her vision over time. Her parents did take her to a different hospital system that I work with. She had to go to the ER on the 16th. They did a CT scan. She said they did some blood work. It was all normal. They sent her home and told her to follow up with ophthalmology, which is what they did. So she saw general ophthalmology. Everything looked normal. They sent her to retina. Everything looked normal. So they called my office and wanted to get her in the same day, so we did. And I took a peek at her. Everything looked pretty normal. And a young girl, given her just kind of her habitus and things like that, I kind of did the workup or kind of some of the questions for pseudotumors. I asked her, about birth control, pregnancies, medications for acne, tetracyclines, any head trauma, weight gain, and all of that was negative as well. So this is her exam. Visual acuity was 20/20 in the right eye, 2200 in the right eye, 20/20 in the left. Interestingly enough, she had no APD, but she had also been dilated earlier that day, so I didn't really trust it. Pressures were normal. Color plates were down in that right eye. She did have pain, full motility without pain, and dilated exam was normal. So these were her fields. You can see that she's kind of got that hemifield cut on that right eye. Left eye looked normal. It was an okay exam. She did have some increased false negatives, but overall, I trusted that visual field. These are her fundus photos in OCT, and everything looked normal there. I know it's kind of small, but there was nothing about that that was swollen or abnormal in terms of OCT. So my assessment was that she had sudden vision loss, she had a field defect, no pain with eye movements, no APD. So I sent her to the ER from my office that day because I felt that she needed some more urgent workup given that she's 16 and can't see out of her right eye. So at this point, what would be your next step in terms of what you'd do? Am I supposed to push something? No. You're good. Okay, there it is. Wow. Okay. Okay. All right. I just pushed the next. Yeah, okay. Okay, looks like we're thinking both MRI, brain and orbits, with and without, and then some labs. So I think that's pretty good. So hospital course, saw her on the 21st. Visual acuity was still pretty much the same. She did have an APD that day. I think that's after the drops wore off. Still no pain with eye movements, no color plates. Red cap desaturation was decreased in that right eye. She did get the workup with imaging. They did an MRA, not an MRV. The hospital just kind of does what they want sometimes. We did do some autoimmune and infectious labs, and then neurology was consulted, and they ordered the lumbar puncture to check for illegal clonal bands, IgG. They did serum as well as CSF aquaform they did some serum MOG antibodies, and they also imaged the whole spine.
They get FLAIR imaging?
Well, that's part of our protocol, yep, so it was, yeah, so when we do, yeah, it's, yep. All right, so continued hospital course. On the 23rd, she was started on steroids. I feel like I kind of got out of order here. Let me go. Okay, so testing completed. So interestingly enough, her MRIs were completely unremarkable, but she did have some demyelinating lesions both in the cervical spine and the thoracic spine. Because everything was normal, we ended up ordering a VEP test, which is visually evoked potential, and sometimes that could be more specific than an MRI of the orbits when you're looking for things like inflammation in the optic nerve, optic neuritis, that kind of thing, and that was abnormal, suggestive of dysfunction of that right optic nerve. The LP did show positive oligoclonal bands. She also had a high IgG index, which is highly suspicious for multiple sclerosis. All of her autoimmune and infectious labs came back negative, fortunately. And both her serum and CSF were negative for the OCT4 and the MOG antibodies. So we'll go back. So after that, she was started on IV Solumedrol, 1 gram for 3 days, and then per pharmacy, she did a 16-day oral taper instead of just 11 to keep her on that 14 days of oral steroids. Her vision did improve a couple days later, and we still saw that APD. Visual fields are always hard to test in the hospital, but they still appeared to be depressed. She's never really had any pain with eye movements. Color plates were starting to come back, and the red cap desaturation was also starting to improve just after a couple of days of steroids. So I saw her back in early February, and she was officially diagnosed with MS. They were really thinking that it might have been neuromyelitis optica or Devick's disease, just given the lesions in the spine. But because everything else came back negative, they finally made that diagnosis of MS. And she was already feeling that the vision in the right eye was improving. Fortunately, after the steroids, she had finished the full course at that point. So at that point, visual acuity did improve to 20/40, no APD. Her color plates were almost back to normal. Color saturation was much better. And again, she looked very normal on my physical exam. And these were her fields. So definitely got a lot better with steroids. So important to act fast on these patients when you don't know what's going on. It's not making sense in the office. Get them some help right away. And this was her OCT. I'm not sure why the other one didn't come up, but we've got the right eye. That's the important one, and that also still looks normal. So, diagnosis of multiple sclerosis. They were kind of at the stage where they were talking about the different treatment options with neurology, and I will be seeing her, I think, this week coming up, and at that point, they should have a game plan of what they've decided to start for long-term treatment with her. All right. Any questions at all? Yes.
So I thought that was interesting. I think, we covered in our curriculum the neuromyelitis optica. So we were talking about anti-aquaporin 4 antibodies are like pathognomonic, where they're like really indicative of that. However, it looks like the testing done, they were still negative in this case. So you're going with the diagnosis of multiple sclerosis. Can you still make a diagnosis of neuromyelitis optica even without those antibodies present, or what would that?
Not to my knowledge. You have to have those positive antibodies for it to be that. Yeah, that, and then, you always want to, I kind of deferred to neurology with that part, but with the fact that everything else was negative and that IgG index being very high, that's also very specific for MS. So although the lesions were a little bit atypical for what you would expect for just MS, I think everything else, kind of led to that diagnosis.
Victoria, if I could offer an alternative opinion, and that's a nice part about having a panel, right, is that we all have different opinions on this. There is such a thing as seronegative NMO, and so it's less common, but so are these antibodies. I mean, I think it's uncommon to get these come back positive. I have maybe 2 patients that are children that have both NMO and MOG antibody positivity. And so this is a very difficult place to be in. A young person who, neurology is kind of thinking about, oh, is this MS, but what are these spinal cord lesions? I'm really glad you're seeing her back again, because they're so difficult. It's not infrequent for me to repeat MRIs 2 or 3 times and to see them every 3 months because mom or dad is nervous it's coming back. And the patient is, in athletics or something like that. And especially in the era of COVID, where they're saying, oh, I need to be vaccinated in order to do anything, and I have this autoimmune disease. And so it's really helpful to kind of just keep an eye on them, I think. I don't worry so much about the NMO positivity coming, but I do repeat that as well. In other words, if I think it is NMO and it's negative, I might repeat it one more time. But once you get the positive, it's kind of like, yeah, this is a slam dunk. But if it's negative, I typically will just keep them real close monitoring.
That's good. Thank you. Yeah. Yes.
Hi, Leslie.
Had this patient been bilaterally in this situation, had presented with both eyes, which would be more typical for an NMO patient who's pediatric, are you starting empiric therapy before you get those antibodies back? Because I know there's a move sort of in that direction. If you think there's a higher propensity for it being NMO, not to wait those 7 to 10 days to get those labs back.
Right. So I think the question for those in the audience was, if it's bilateral, does that change your management? Was that fair to? Okay. So I think so. For me, I am looking at these MRIs. I don't think anyone looks at the optic nerves like the ophthalmologist does. Even the neuroradiologists are missing these. And I think it's important to also confirm that you have fat saturation of your orbits. Because, oh yeah, the MRI is normal, it didn't come back with any optic neuritis, or, oh, it's on the right side, because that's where the majority of it is. But if you do see enhancement on the left side, and no one else saw that, that's important information. And that may explain why there was no APD initially. In this case, we found one as she came back undilated, but it's pretty common for that to happen too. And for it to be asymmetric. So I would say first, the answer to that question is first, I would look at my own imaging. And if there is a long area of enhancement of the optic nerves, I'm worried more about MOG, even in the setting of bilateral. If there is bilateral, really deep visual loss and visual field cuts, then I'm worried more about NMO, but it still could be MOG. And as far as treatment, I think both of those deserve, as was done here, urgent or emergent steroid administration. And a taper is a really good idea because sometimes they can relapse during the immediate post-treatment time. But also it gives them a reason to come back. Well, when do I stop these pills? And sometimes the neurologist will feel very comfortable managing those, but they'll also give a different course. Okay, well, we'll see you back in 6 months. I have so many patients, I can't see, you again, and you're doing great. Whereas we're the ones checking the vision, we're the ones seeing the APD, we're the ones seeing the color, and so they're going to rely, the patient and the neurologist, heavily on us. So it's important, I think, for the follow-up, just like Victoria had here.
I think the interesting thing too was that her MRI was stone cold normal. I mean, I even looked at it. We even had radiologists go back and recheck and say for real, is it? Can you look again? And so the VEP here was the only thing that was abnormal about her optic nerve because I knew something was going on. She had decreased, vision, visual fields, all of the APD. So have you experienced a lot of that where it's negative in that sense?
Absolutely. I
Yeah.
think it's a very important point in this case because optic neuritis is not a radiologic diagnosis. It's actually a clinical diagnosis. So unfortunately, this patient did not have pain on eye movements, but that would have been my first, clue. And then APD, visual field, visual acuity, and color vision problems all point directly to optic neuritis. I would say in the setting of no MRI, you do the MRI to confirm, and in this case, it did not show it, but it also didn't show a big massive tumor. So that's kind of nice.
Yeah. Yes. Any other questions? Yes.
I think any of us that have been to any of these meetings in the last several decades got to know Dr. Kaufman. And I think one thing on your slide that popped up that just kind of got glossed over, which if anything he's ever taught me is don't ever ignore the natural course of the disease.
Mm-hmm.
And did they just go rogue on their steroids? Or since you guys are kind of thinking
Mhm.
age range, the diagnosis, it seems weird that they just empirically said let's add on an extra week of steroids.
That was based on pharmacy, because even we recommended the 3 days with the 11-day taper, and then same with neurology when I was looking back at the note, and it said on discharge that was per pharmacy dosing that they decided to do the 16 days. So that was neither service. It was pharmacy that kind of like hopped in there and decided to do that. So, and the patient was compliant. So there you go.
The answer is yes.
Yeah. Yeah. Yes. Any other questions? Okay.
All right. So, I don't know how to get rid of that thing. There we go. I was an advisor for Horizon when it existed. It's actually important for one of these cases. I won't discuss anything because whatever. So it's a 13-year-old Caucasian female, presents with about 3 to 5 months of headaches. I already saw her after she was in the hospital and got the full workup. Her only medical history is a congenital athyroid. When I met her, she wasn't really being treated with anything because the dad kind of like, well, when she's doing fine, they stop medications. She had neuroimaging was normal. The opening pressure was 48. That was her refraction when I saw her. She was 20/20, and those are her nerves. Not too bad, a little tilted. She was myopic, and then I decided to get they got the OCT. OCT is definitely a little bit thick and elevated in both eyes. You can actually, there we go, I think. You can see really the elevation. It's not just that it's tilted. They're really actually elevated. Field's definitely showing a little bit of a deficit in the right. So what is everybody thinking at this point for this girl? It's a trick. So you have a 13-year-old girl, slightly overweight, not obese, presents with an opening pressure of 48 and what looks like papilledema.
My first thought would be idiopathic intracranial hypertension.
100%. Especially with normal neuroimaging, opening pressure. The kicker here is that she had that's not, can we get this up so the panel can see? So she has 4+ cell and 2+ flare in both eyes. Lens is clear. So now that we have papilledema, elevated opening pressure, and bilateral anterior uveitis, Tim.
Yeah. I think in the absence of the lumbar puncture, this could just be anterior uveitis. I've seen that cause bilateral disc edema, but now we have opening pressure elevation. What was the CSF analysis?
Normal.
Normal. Yeah, I've got nothing.
So I'll be very, very honest. I did 2 things. One, the rheumatologist told me what he thought. And then yesterday I was like, you know what? I already knew what the disease was. Let me put in the findings, and I'm going to throw it into ChatGPT and see what happens. And I specifically asked ChatGPT for the differential. I didn't ask them for the diagnosis. You can't diagnose without anything. But so I shifted away from neoplastic just because of the normal neuroimaging. It's been going on for 3 to 5 months. Infection is much less likely because it's 3 to 5 months and all she has is some papilledema and uveitis. Nothing else really going on. So the infectious causes, TB, syphilis, toxo, HIV, Lyme, all the imaging and the blood work were negative in the hospital.
How about her skin? Any skin lesions?
Nope. But you got the diagnosis. But there were no skin lesions and there's no eyelash or hair changes. So we're going to go down the road of autoimmune. So you have sarcoid. She was full body scanned. There was nothing. Behçet's, there was no hypopyon. There was no other sign, no oral ulcers, nothing like that. Lupus is always in there. Even with negative antibodies, you still have to think about that. And then VKH. So the rheumatologist called me. He's like, this is VKH, and I'm starting her on methotrexate and Humira immediately. So what I did is I started her, oh, look at that, Diamox, Pred, and a dilating drop. I think it was atropine at that point, whatever they were able to get, which is kind of how I treat it. It's like atropine, but let me know, and I'll send you cyclo or tropicamide if I can't. And the Diamox was able to keep the pressure down. And yeah, there was a little bit of a fight between the uveitis and the papilledema. And my real question of like, did I really need the Diamox when she was being treated with the methotrexate and the Humira? But although those take a little while to kick in, so those were kind of like my thoughts of like, did I actually need the Diamox? I'm not sure. I started seeing her in 2022, and she relapsed 2-3 months ago because she lost her insurance and couldn't get the Humira. So that completely relapsed. But back on, I didn't do Diamox, back on the Humira and back on the Pred, and the uveitis is going down, and the papilledema that she got again, which is now going down just on the Humira. Would you have done Diamox?
I love that question. I'm a pretty big fan of Diamox, actually. It's not indicated, I think, in this situation, in the sense that, like, if you don't do it, you're in trouble. But when you have elevated pressure like that, the rheumatologist, raise your hand if you have a rheumatologist and get your patient in tomorrow or a year. Oh, we have one in the audience. Wow.
I have 4 rheumatologists, pediatric rheumatologists.
Oh, wow.
That I get my patients in tomorrow.
Well, that's fantastic.
Because I do the same for them.
That's great. Yeah, establishing those relationships is incredible. I think that's a very good take-home message. I would ask, too, how was the hearing?
She never complained of anything. I'll ask her next week.
Yeah, that would be one thing. And then how about the periphery? Anything in the retina other than the swelling of the nerves?
No.
Very interesting. Sometimes, if I'm, like Optos is a very good, especially in children, very good modality to use because, they're not super cooperative a lot. And you could also do the red-free Optos, and some of these will have choroidal changes that are very subtle. And then the hearing, but yeah, no skin lesions, no coloring of the hair problem. Oh boy, this is a tough case.
It was. When he said that, I was like, I have no idea what you're talking about. Like I have another VKH patient, but like classic, much more classic. And I was like, they get high pressure. I was very surprised. So that's kind of the first case. Any questions about this? We're going to jump to a more plasticky case next, plastics and neuro. Any questions? Yes.
Just so I understand, the Diamox was purely because of the
Opening pressure. Yeah, that was it. It's pressure of 48, and it's likely caused by the inflammation of the meninges due to the VKH. So the patient was actually already started on Diamox before I saw them. So I was like, you know what, there's papilledema. Let me wait till there's no papilledema, take them off the Diamox. And the steroids were there for a very long time, the topical steroids. Also, sometimes we had some like understanding issues of what she was supposed to do. So like she wouldn't go up on the steroids, but then she'd stop those types of things, the normal things.
If I could add to that, I think it's important to tell the family this is something we're get off of. I have several patients that have had secondary cause for elevated intracranial pressure, and they maintain that diagnosis of IIH. And I just think it's, maybe not idiopathic at this point. We have an autoimmune disease. Even the first case, multiple sclerosis, can present with elevated intracranial pressure. And so if it's not idiopathic, you don't really need the Diamox, but I like it in this setting where it's an unknown diagnosis until it's known, and then you can taper right off.
All right, let's have some fun with a little bit more classic case. This is a 68-year-old male, presents with recurrent double vision, has a history of strabismus surgery in 2005. He was being followed by NeuroOff since 2007. About a year ago, he presented like this. Would anybody like to give me a diagnosis? This is thyroid, yeah. So he presented like this and had nerves like this. So for everybody out there, what is the next step when you have a thyroid patient with nerves like this and pretty bad visual fields? I didn't have a copy of the visual fields.
Steroids or imaging,
So yeah, so it's compressive optic neuropathy, 100%. And really, the question that I'm going to pose to the group is: do you jump to a decompression? Do you call Amgen and say, "Get me emergent Tepezza"? I know what was done with this guy, but what's your guys' take, our plastics person?
You said his vision was decreased?
His vision was decreased. There was papilledema, and there were definitely field defects.
In that case, I would put him on steroids, and I would probably call Amgen and see if I could get some Tepezza. And if things weren't getting better quickly, then I would probably just decompress him pretty quick. I'd have him like tentatively on the board that week if we're not getting improvement. So.
There we go. So that's my question: is you'd wait 1 week, bring him back, and
No, I wouldn't. I mean, I'd see him like a few days later. This is someone I would see urgently, like that day, start him on something and see if there's any improvement at all. And if we're not making any headway, I would just decompress them personally.
Mm-hmm. So this patient, even when I saw him afterwards, refusing Tepezza. He did not want it. And I get this. Maybe about 5-10% of my patients, they hear about the potential hearing loss, and most of them do. When they go on it, they actually get they complain to me about the muscle pains and stuff like that. But they're happy with it because it works. But the hearing loss is kind of a big thing for a lot of my patients,
Yeah.
even though it's potentially not even true. Although I do have one patient who lost full hearing in one ear at injection 7. So, yeah, this guy just didn't want it, and we got a decompression on him. So I saw him back 2-3 weeks ago. This is what he looked like. He had normal OCT, relatively normal OCT. Normal OCT in the right, left definitely had some damage, probably from the papilledema that he had from the compression, and then he came to me and he's like, "I want you to fix me, and I don't want Tepezza." So the MRI here shows a lot of muscles that are enlarged, and he has some pretty. We have and his eyes are. That's him. So those are his eyes. There's basically almost no movement in the left eye. There's pretty much no movement in the right eye.
Austin, can I ask a question?
Yeah, go for it.
It looks like he has a little asymmetric face as well, especially inferiorly. Is there anything with a 7th nerve?
Maybe. I know imaging was normal. I got him after neuro and plastics had already finished with him.
And then for those in the audience that are the students, there are particular patterns to the muscles involved with the thyroid. And it's not common to have all of your muscles. I mean, we have the superior rectus involved, which is a little atypical. And
I've
then-
had superior oblique involved. I've had weird stuff.
Oh, absolutely, absolutely. Just in the setting of that facial palsy looking thing.
Yes,
Covered his right eye, does left eye go straight?
absolutely not. No, those eyes don't move really.
That was for sure enlarged muscles.
Oh yeah, that eye does not move. I'm going after that one. So the discussion that I have, number one discussion I have is Tepezza is going to make my life easier. For the muscle surgery, they're just easier muscles to work with afterwards. They become more elastic. He refused it, so I'm like, okay, let's go do surgery. The things that I look at, because number one is he has a tight inferior rectus on the left. I'm not touching that. I am going to touch the superior rectus on the left. I am going to touch the inferior rectus on the right. And yeah.
Did you not do steroids? Since he doesn't want Tepezza, did you treat the inflammation
Oh
with
yeah, he got steroids and
Like high-dose
decompression
steroids?
already.
Oh,
Oh,
okay.
he's post-decompression for me. Yeah. So he's 100% post-decompression. I think he had a 3-wall decompression. He had a big one. But the things that I kind of give him a warning about is the torsion, because I'm playing with some non-opposing necessarily muscles. And that he's likely going to need another surgery, and he's not going to have great motility because I'm not touching a tight muscle, because if I relax the inferior rectus on the left, it's going to bring the eye up, and I don't want that. But it's a tight muscle. I'm going for both medials. I think he was about 30 of ET plus that big hyper, and I'm going for the right inferior and the left superior, which is probably going to cause some torsional stuff, but he's going to be a lot happier afterwards. And I did tell him it's likely going to be a second surgery. I'll deal with the torsion after the first one, if he has any. And he's been dealing with this at this point for like a year or two, because as a second time he's dealing with it. So any other thoughts, comments, anything about this case? No, I really, he looked at me and like, no. I'm like, okay, you already went through 2 guys who are like big Tepezza guys. I can't. Between the 3 of us, I'm probably the number 1 Tepezza as prescriber in Florida. The other 2 are numbers 2 and 3. So if he got through them, and one's a speaker. So if he got through them and then like the first words out of his mouth were no, it's just not happening. I wish I could have. So questions from the audience about that, about Tepezza. I'm sure we could all probably speak about Tepezza. Yeah.
How quickly would you see results with Tepezza?
So that's a really, really good question. So one of my first patients told me that after the first injection, he felt really, in terms of strabismus, you're asking me, or in terms of? In terms of strabismus. So the answer is the third dose. One of my patients said he felt better after the first dose. I saw him after the first dose. There was no change in his motility pattern. It's really after the third dose that you start seeing stuff, and then you continue to see it over the rest of them. The other thing is there's a really great article that came out recently basically showing the younger you are, the better you respond to Tepezza. I have an 80-year-old who had 0 response strabismically to Tepezza, and that was her only issue. There was no other inflammation going on, really. The other stuff works great on, but it's all really after the third dose.
If I could just, I think this case shows an opportunity to talk about the real world, and that is this does work in the majority of patients. I think it should be the first line. But when they say no, or when you've already done it 2 times, what do you do? I think the U-GO-GO criteria, the European criteria for steroids is one option. Another option would be radiation. They come in for orbital radiation, every day, 5 days a week for about 5 weeks. That showed some. And next question is, well, how do you know you're done? It's helpful to follow these with the serology. So I order, all of the antibodies, all 4 of the thyroid antibodies, the TSH, the T4, those could be totally normal, right? About 10% of patients with thyroid eye disease are going to have euthyroid. So it's mainly these autoimmune thyroid markers. And if they're going down and the strabismus is stable, then I think strabismus surgery is a good idea. And in this case, there was a need for, decompression. I think that's an important part of this as well.
Right. So the other two things is I follow the TSI and the TRAB. I was taught TSI in fellowship, and then after fellowship, everybody's like, follow the TRAB. All the plastics people are like TRAB. And the other thing is that I did warn him is he is absolutely getting eyelid surgery as soon as I'm done, because those eyelids were already really bad, and he's gonna have a ton of exposure on the right. So that's the other key is like this was like a classic decompression strab eyelid, a very classic like board question, and it's happening in real life. Yeah.
So I'm just curious, I'm not familiar with this drug in particular, but what's the association with the hearing loss as a side effect?
Great question. Next.
Tepezza's, in full disclosure, I am a speaker for Tepezza. So, I mean, Tepezza has been out since 2020, and it was more recent that they realized that it's causing, or it can cause, permanent sensorineural hearing loss. It is a small percentage of patients, about 5%. And once that came out, I asked my patients who actually were on it, have you noticed anything? And some of them said, now that you ask me, I kind of felt like I was on an airplane. Like when I was getting the infusion, it was like muffled.
Yeah, I get some tinnitus sometimes. I get the muffling. Yeah. Those go away though.
It went away. And it usually didn't even last the full time because it's 8 infusions, 3 weeks apart, so it's 24 weeks of treatment. But usually it was like right after their infusion for a day or two, and then it came back. I personally have not had any patients that have had permanent hearing loss, but I've started getting baseline hearing tests on everybody, so that way, if they notice anything, we repeat it. If it's gotten worse, we just stop the infusions. But
yeah, there's a push to get the hearing loss after every 3 infusions. And then you could, if there's any changes, most of them still want it. So I do have, I've had a few patients with like that muffled or tinnitus. And one of the pushes is to spread out the infusions to every 4 or 5 weeks instead.
I just increase the infusion rate. So the first 2 infusions are over 90 minutes. I just do everything at 90 minutes instead of 60. If they're having like the muscle aches or anything, I make sure they stay hydrated. I increase how long they're giving the infusion, but I don't necessarily stop the timing. But typically people are so happy that their eyes are looking better and they're feeling better. They're like, I'll go deaf. I mean, not that I'm saying you should promote that, but for the most part they are.
I've had
but,
2
yeah.
tell me that one actually came back with the baseline hearing loss. Like she actually had it. She's like, I don't care.
Yeah, I mean.
She's like, I'm fine going deaf. I need to fix this.
Yeah, a lot of times they're just so much happier and they're in less pain. So, but again, that's a very small percentage. I personally, I've been prescribing this since it came out. And then another thing to remember, there's some people that just go rogue. And so I learned from 2020, like so Tepezza came out in 2020 and then the pandemic hit and then the centers that were making the drug actually had to stop making it because they were forced to make the vaccine. So I had people who were in the middle of infusions that had to stop. We couldn't get the medicine. And then once we could, we restarted them and they still had a good result. So that's to be said, like if for some reason they had to stop because they were sick or this or that and they go a few months without their next infusion, you can still get back on track and they still have the same outcome, in my opinion, as if you would have kept on like every 3 weeks. So that's not like a must. You could extend it and still have a good outcome.
And another question is, what's your timing on after infusion? When do you do strabismus surgery?
I mean, the same as her, within 6 months.
Within 6 months. So I have a paper that I'll be presenting tomorrow, so you'll find out the results tomorrow if you show up 10:30. Yes.
What about the patients that are chronic thyroid ophthalmopathy and never received any treatment? What's our results with Tepezza or where are we with that?
Those are new studies that came out 3 months ago?
So that was their phase 4 trial. So now it's indicated for all forms of disease. It's not just acute disease. I find my chronic patients are the ones that typically will need a second round. Usually they get something out of the first round, but a second round is usually when they see more improvement. I have some patients I've inherited from other docs that they've had everything. They've had decompression, they've had muscle surgery, they've had eyelid surgery, they have what I call bad real estate. You've used it all, so I don't have a lot of options in terms of how I'm gonna treat your exacerbations, so I put them on Tepezza, and usually the proptosis gets better, the movements,
the restriction and the fibrosis they have of the muscles gets better because you get that acute amount of inflammation. You're not going to get it perfect. It's not like a newly diagnosed thyroid eye disease, but you still will get some improvement with your chronic patients.
Eunice Mayakohara from California here, pediatric ophthalmologist, private practice. I'm going to present on one of my patients. I have no disclosures. So in 2021, she's a 6-year-old female, presents with a right-sided facial weakness and the redness of the right eye, and the symptoms started a month prior. The history was a month ago, she was sick for 2 days. The COVID testing was negative. She had a fever, runny nose, and cough. And then 8 days later, she presented with right-sided facial weakness. So her pediatrician started her on artificial tears. Family history, maternal grandfather deceased from cancer, not really contributory here. Exam 2020, motility was normal at this time. She was ortho. She had the right-sided weakness with the forehead sparing, good Bell's phenomenon, lag ophthalmos of 3 millimeters, poor eyelid closure. The slit lamp was pretty normal with the artificial tears. She was doing well. So what's your impression? So facial nerve palsy, what do you think is causing this? Is it idiopathic, infectious etiology, myasthenia, trauma-related, neoplastic, inflammatory? What are your thoughts? I'm surprised no one's choosing idiopathic. Any more responses? All right. So actually, most common cause is idiopathic Bell's palsy. And then you have you have congenital causes, delivery trauma, syndromic, like Mobius syndrome, genetic causes like myotonic dystrophy, myasthenia. You got acquired causes, which are infectious, any of these, even acute otitis media, chronic otitis media, inflammatory, Kawasaki's disease, neoplastic, schwannoma, hemangioma, sorry for my misspelling right there, and then traumatic temporal bone fracture or iatrogenic from surgery of the parotid or middle ear. So what would you order for this patient? So if you're thinking idiopathic, probably nothing. Maybe viral serology. So viral serology for herpes is one of the thoughts. EBV. CBC might be looking at monocytes, lymphocytes, which are associated with idiopathic. Imaging is usually normal with idiopathic. Would you start them on steroids, prednisolone? Would you start them on an antiviral? This is day one, first visit. What would you do?
I'm Dr. Charles
Is this like a Bell's palsy?
This, so presumed Bell's palsy.
So, presumed Bell's palsy, I would throw them. If it's a presumed Bell's palsy, the real treatment is antivirals and steroids as quickly as possible because it's presumed to be a viral etiology, at least for some people, but she absolutely needs the neuroimaging first. So like these patients, I always send straight. I have a couple of them that I just send straight to the hospital, and like at Children's, by Miami Children's by me, they'll just like call me on my cell phone and say, what do you want? And they're really easy to admit patients. So for me to get like an MRI, especially, this was an older kid, right?
Yeah, so this is a month out. That's the clue. It's been already
been
a
a
month
month.
since
Ugh.
the
Yeah,
onset.
then there's, no.
Okay. I have
No
not
great
much time,
treatments.
so I'll keep
Yeah,
going.
you need to just get the imaging then.
Yeah, imaging. So the biggest problem with her is she had lagophthalmus and exposure keratopathy. So I wanted to go over like what you would do, plastics, artificial tears. There's this Nictavi tarsus eyelid patch. In conversation with someone, they gave me a sample. I gave all of my samples to her. Bandage contact lens, Procara for amniotic membrane, Tarsarafy, implantation, temporal weight, implantation of a temporary weight in the upper eyelid. These are some options. At this early stage, we just did conservative artificial tears. So 2 months of onset, she came back. She complained of headaches, now going on for 2 weeks. It was alleviated by Tylenol. Now the forehead was involved. She had now corneal epithelial erosions, and the viral studies were negative. She hadn't had MRI imaging yet. So during the next month, she had imaging done. This is not her image. This is just borrowed from another paper, but very similar. Here you can see there is a lesion in the pons T2 flare, and diffuse involvement of the ventral area here, and encasing, this one is encasing the bilateral artery, basilar artery. And then on 3 months onset, they did a biopsy and it came back confirmed H3K27 and mutated diffuse intrinsic pontine glioma. And then by 9 months, she came with she now has nystagmus, rotary, and shimmering of the eyes, and the eyes are now turning inwards. She's got right-sided weakness of her body and tremors. And by 10 months, her vision went down to 20/25 in the left eye with a right esotropia of 60 prism diopters and corneal opacification, a corneal ulcer on the right eye. So very difficult for us to treat as ophthalmologists. Right corneal ulcer, decreased corneal sensation. So just quick overview. This is diffuse lesion. Its intrinsic origin is in the pons, and it's a glial origin. It affects children primarily between ages 5 to 7. Affects 10% of of all brain tumors, and it's 80% of all brain stem gliomas in children. There's about 150 to 300 cases, new diagnoses each year in the United States, and the survival rate is between 9 to 11 months. So just the classic triad here, she didn't present with the classic triad. The triad is abducens nerve palsy, ataxia, and then pyramidal tract dysfunction. And that's it.
So with Bell's palsy patients, I tend to do tarsorrhaphies pretty liberally. I mean, especially if they come in and they have any SPK and you know they're not closing their eyes completely. I tend to just go ahead and do like at least a temporal aspect just to make sure that when they voluntarily close their eye that I close enough that when that happens they're closing completely, in addition to making sure that they're doing ointment sometimes throughout the day, not just at nighttime, like 3 or 4 times a day, and artificial tears every few hours. That's how
I think for a patient that's not severely debilitated, like bedbound, I try to avoid the tarsorrhaphy if I can, and I usually refer to a cornea specialist that can do a PROS lens to try to cover do a scleral lens, covers the cornea and protects it. Another option.
So,
Temporal torsorrhaphies are easy, and then you just snip them in the office.
And you'll never know it was there.
they opted for conservative management just because of the prognosis of this condition. I did try the taped eyelid, and the tape would just roll right up, and actually the tape would start scratching her cornea, so it was not a
Irritate the
good option.
skin. Yeah. Long term.
Yeah. I think we ran out of time. What do you want to do?
Yeah, we've been discussing that already.
Okay.
I think we invite our next speaker.
Okay. Great, thank you.